started. If you have any questions or you need anything on the platform, feel free to chat us, and we'll be monitoring the chat function. But we'll be getting started in a couple minutes. Hi, if you're just joining us, we're going to wait a couple minutes to get started as people join the webinar. We'll probably get started at 5 after the hour. Hi, everyone. If you're just joining us, we're going to be getting started at about 5 after the hour as people join the platform. If you have any questions about the webinar platform, feel free to chat us. Just going to wait one more minute, and then we'll get started. Good morning, everybody. My name is Steve Lucas. I'm with the Council of Large Public Housing Authorities. We want to welcome all of you to today's webinar. We're very excited to have everybody on the line today to talk about health and housing partnerships. We had a very exciting endeavor with the Public and Affordable Housing Research Corporation, PAHRC, earlier this year, and released a report of our findings. Before we get into the webinar, just a couple of housekeeping items. This is a new webinar platform for us. It's called Quick Meeting. So if you have any bumps in the road with technology, feel free to chat us. My colleague Micah O'Brien here at CLPHA will be monitoring the chat if you have any technical issues. You can also use the chat if you have any questions throughout the presentation. Just let us know if you need anything. In the top left corner, you'll notice that there's a section called Share Files. You can download the PowerPoint from today's presentation, the report that we produced with CLPHA, Health Starts at Home, which does an overview of the survey results. And we also included 2 reports out of HUD last year, one looking at the health of adults living in HUD-assisted housing and the other children living in HUD-assisted housing as additional resources. Today's webinar, you'll be in listen-only mode for most of the webinar. At the end, we're going to have a Q&A where we'll allow people to ask questions. You can also ask questions in the chat, as I said, but you'll be able to ask them verbally as well. We encourage you to share your perspectives from the field, ask any questions you have about our survey, about the health sector, or if you're from the health sector, I know we have some attendees today, about PHAs and the role that they play, the critical role they play in this industry. If you have any follow-up questions for us after the webinar, we'll be including our emails. Feel free to reach out to us, and we look forward to the conversation today. So just to give an overview of what we're looking to cover on today's webinar, we're going to provide a pretty detailed overview of the results of the national survey we did in conversation with PAHRC. We'll go through some of the domains from the report, the nature of these partnerships, the types of priorities that are set. We'll also, in doing that, talk about what are some strategies for health initiatives at the PHA level. How are PHAs working with health partners? Many of you have forged relationships with the health sector, and those are typically at various stages. Even if you have, let's say 5 different health partnerships, some might be more mature and trusting, and others might be new and more tenuous. Or you're interested in figuring out, how do we work with a hospital? How do we work with a federally qualified health center? We know that diabetes is something that our residents are concerned with. Are other PHAs working in that space? At the end of today's webinar, we'll have sort of a sharing and Q&A session. We encourage everyone, like I said, to share your experiences with your health partnerships and health initiatives, what this looks like on the ground. While the survey provides a really nice sort of first-of-its-kind national snapshot of these partnerships, filling that story out with perspective from the ground is critical to this work. In addition to that, we want to allow for time for Q&A to ask us questions about the report and next steps, but also if there's questions you have of peers or your partners in other sectors, feel free to share those as well. So I just wanted to thank, first of all, PAHRC, who has been an excellent partner in this work. CLPHA actually started this survey last year. CLPHA represents 70 of the largest public housing authorities in the country in major metropolitan areas. Think LA, Chicago, Seattle, Atlanta, all over the country, and our members manage a substantial number of units and are responsible for a number of households. We did a survey of our membership, and the results of that is actually in the recent Cityscape journal out of HUD that was just released the end of last month. And we looked to expand the reach of that snapshot from our members, which gave us a good starting point. We wanted to reach a larger number of PHAs and a more nationally representative sample. PAHRC helped us refine the survey and also expanded our reach to additional smaller and medium-sized PHAs in addition to large PHAs. So I wanted to introduce Keely Stater and Kelly McElwain to introduce themselves.
Hi, this is Keely Stater. I'm the Director of Research at PAHRC. And for those of you not familiar with PAHRC, we're an independent nonprofit research organization that looks at issues in affordable housing policy. And we work a lot with CLPHA and some of the other industry organizations.
Hi, I'm Kelly McElwain. I also work at PAHRC as a research analyst, and I'm responsible for publishing some of the research and data tools released by PAHRC that help build the evidence-based case for why affordable housing matters.
All right, thanks. And just to give you a little more perspective on CLPHA, we do represent sort of bread and butter housing issues, like we like to call them, but also a lot of our work has moved into encouraging and fostering cross-sector partnership. To date, we've done a lot of work in the education sector, fostering partnerships among public housing authorities and schools, superintendents, education nonprofits, and more recently in the last couple of years, looking at the intersections between the health and healthcare sectors and housing. I I co-lead our Housing Is initiative. Housing is Health, Housing is Healthcare, Housing is Education, and we host an annual conference in May here in DC. So this work is an extension of our Housing Is initiative. So for today's webinar, we wanted to introduce people to the results of this report and also provide a forum. It's been hard to know on this topic what's happening at the national level. We haven't had a national snapshot. Even when I joined CLPHA, it wasn't clear, what partnerships are PHAs writ large engaging in? What priorities are they setting with their partners? And this survey is a really important step in learning that. And so we also want to learn about efforts taking place at PHAs. What the survey doesn't articulate is exact programs, like all the details and sort of all the mechanics of a partnership, the depth of those partnerships. But what we can provide is a sense of what kind of priorities are being set, what kinds of health organizations are being engaged. And as you'll see, there's a great diversity of partnerships across PHAs. And so there's not one way this is happening, and there's a lot of opportunity in this work. We also want to look to identify strategies that will work for your agency and help expand efforts. This is a sort of broader and longer-term effort we have at CLPHA. But these cross-sector partnerships can sometimes be a perpetual wish list item for agencies both in the housing sector and in the health sector, that have a lot of other things going on. The types of agencies that are serving low-income families and individuals typically have a lot going on, and the cross-sector partnerships can require a lot of attention and time and financial resources, and we recognize that. But we're looking for scalable and sort of lowest-hanging fruit solutions to start and then growing from there. And we also want to continually encourage PHAs to learn from each other. We encourage you to share your experiences today. It'll help provide greater context to the findings of this report and help inform our thinking for the future. So just to get into this topic, it's important to note that in any of these cross-sector partnerships, everyone sort of wants to do something in another sector. We know it makes sense. It's common sense that systems and program-level staff should work together. But forging these partnerships can be difficult, especially at the early stages. So going into this, you want to think about how are you going to build a relationship with a specific organization? How is your agency going to understand what you need to know and what you don't need to know about the other sector? Not getting too in the weeds based on what you actually need to know, and just doing a basic portfolio sharing. Sharing what a PHA does. What does your day-to-day look like? What keeps you up at night? And asking the same question across the table. It's also helpful to do some level setting about similarities, differences, overlaps, and strategic priorities you have and how those all match up. But it's important to note that across health and housing and healthcare as sort of a part of the health sector, that there are competing priorities. There are differences in the coverage of your respective populations and services. For instance, in the health space, public health insurance programs are typically entitlement programs where if you qualify based on income or disability status, you're entitled to those benefits. It's not fully comprehensive in that there's gaps in enrollment, but typically people can get access if they qualify for those things. Funding for health is typically driven at the federal and state level. There's always, other components, but the work that's being done for Medicare, typically at the federal level, Medicaid typically both federal and state. States can vary quite a bit. But in housing, one thing that people are surprised to hear is that funding is driven at the federal level. A lot of CLPHA's work is around the budget and appropriations, because so much of the policy is driven at that level. And that's usually an aha moment for health partners across the table. So just getting to know each other is a really critical first step, and also an important way for us to frame these conversations to know that there's not full alignment already, but there are opportunities. We think it's important too, with PHAs, you often have to demystify what a PHA does. Public housing authority, what role do you play, and who do you serve? And we're seeing more and more evidence. We're including the HUD reports as one indication of that, that people living in HUD-assisted housing, for a number of reasons, are showing higher rates of, important medical health conditions, mental health conditions. For instance, the rate of heart disease and for people in HUD-assisted housing is about 20% versus a comparable portion of the population that would be 12.8%. Diabetes, those living in HUD-assisted housing is around 18%, where in the general population is closer to 9.5%. So there's growing evidence that the people living in these accommodations typically have higher health needs, and the argument to the health sector should often be, we are housing the people that you need to better serve and need better access to services. How can we better connect? One of the more encouraging findings of recent reports is that there is higher rates of insurance coverage. So it suggests that people in HUD-assisted housing, when you compare to people of similar income levels who aren't in housing, they do have higher rates, which suggests that once connected to one system, they're better connected to others. Another key message that I think we're seeing resonates with the health sector is that PHAs are key health partners if the health sector really wants to do social determinants work. And what I mean by that is the health sector is often looking at what are social determinants that influence health outcomes. Housing always ends up at the top of those lists. It could be economic opportunities, employment opportunities, and other contexts. But housing continues to be at the top of that list. And while there are some practiced solutions, I'm thinking of supportive housing, which is sort of an evidence-based model we've seen really adopted across the country. The question remains, what can large systems do that are low-hanging fruit to just better align themselves and better work together as a standard course of business? And so in the report and on this slide, we included just some high-level details about PHAs, that there are almost 4,000 PHAs. PHAs collectively manage almost 4 million subsidized housing units. And knowing too, just like if you're thinking about Medicaid, you need to know sort of what does Medicaid cover, what does it not cover, what are the income thresholds. Your health partners will also appreciate knowing that your residents are typically paying 30% of their earned income. That's not always something people understand and what that means. And also just giving a sense of average household income, which as of 2017 was about $14,000. And I'm sure at the local level you have more precise data to that effect. But just trying to cover these bases with your health partners can really set you up for the right conversation. I'd like to say that at CLPHA, we're building our understanding of this intersection. We have a lot of expertise in terms of the housing sector, obviously, and trying to make the case too that PHAs, setting them apart from other housing providers. PHAs have significant scale in terms of number of households served. They're providing essential services for people. The other thing is housing authorities typically have trusted access to individuals and families, and these families, like we said, have complex health needs. That can be a big barrier for an outside health institution, is making a connection with people living in your communities. Also, PHAs exhibit local decision-making capacities that can help with flexibility, and the other thing is they're well integrated into communities, and so there isn't a reinventing of the wheel when you're building these partnerships. It's more about linking all of these pieces together. So I hope that's a helpful framing of sort of where we're starting from and some of our thinking going into this. I am going to have our colleagues at PAHRC go into the methodology of the survey that we did, why we did the survey, and provide some of the results from the report and go into greater detail. So I'm going to hand it off to Kelly McElwain from PAHRC.
Thank you, Steve. So while PHAs have long been engaged with health partners at the local level, previous research has only documented health services and partnerships at HUD-assisted properties for seniors. So the goal of the survey was to provide an overview of PHA health initiatives to lay the groundwork for further training, partner outreach, and research. And as Steve mentioned earlier, as a starting point, CLPHA surveyed its members on their health initiatives and partnerships, and then partnered with PAHRC to expand the survey to include all housing authorities. The survey was administered to all PHAs electronically between February and March of 2018 and received a response rate of 8% or 178 unique PHA responses. To better represent the population of housing agencies, the survey data was proportionally weighted by housing agency combined program size. The respondents tended to be larger in size than the general population of housing agencies, and they were also more likely to operate both housing choice vouchers and public housing programs. The respondents were well distributed by census region, with slightly more agencies responding from the South than are represented at the population at large. And the survey data was featured in 2 reports, which you can find on the top right-hand corner or top left-hand corner of the screen. So the survey provided the first national snapshot of PHA health initiatives, the conditions and populations that housing authorities target through their health initiatives, the types of health partners they're engaged with, how housing authorities are working with health sector partners, and the barriers they face providing services or that prevent them from providing services. So our research finds that half of housing authorities are engaged in health initiatives, and that large housing authorities, measured in terms of number of total units, report higher rates of health partnerships compared to small and medium-sized PHAs. And going back to that, most of these agencies rely on partnerships to provide these services and programming to some extent, and that most of these partnerships are informal. However, a strong minority are complex and have some form of data sharing or MOU. So, and that small and medium housing authorities reported having no formal agreement in place more frequently than large housing authorities. So it does appear that there's a capacity for providing these services and scalability for agencies located in larger cities. But housing authorities of all sizes are providing services across the country. So we had asked housing authorities which health conditions they targeted through their health initiatives, and then we categorized each of these initiatives into 5 categories, including preventative health, medical health conditions, substance use disorders, behavioral health conditions, and physical disabilities. Preventative health was the largest overall health condition targeted by nearly 3/4 of housing authorities with health initiatives. And further, over half of housing authorities with health-related initiatives target medical health conditions and substance use disorders. Meanwhile, only 1/4 of housing authorities with health-related initiatives target physical disabilities and behavioral health conditions. And these trends were fairly similar across housing authority size. However, large housing authorities may have a greater capacity to target multiple health conditions. So the conditions included in each of these broad categories are listed here. So preventative health conditions include conditions such as general wellness, prenatal care, STIs, dental, vision, infant mortality. Medical health includes diabetes, heart disease, obesity, and asthma. And substance use includes tobacco use and substance use disorders. And behavioral health includes anxiety, depression, dementia, and severe mental illness, including schizophrenia and PTSD. And the most common conditions targeted by half or more of all housing agencies with health services included tobacco use cessation, general wellness, diabetes, and heart disease. And meanwhile, more than a fifth of housing authorities with health initiatives also targeted substance use disorders, physical disabilities, general anxiety or clinical depression, obesity, and asthma. And it's also important to note that even for some of the conditions with a smaller representation of housing authorities offering initiatives that target those services, it is possible that there could be an effort led by a state. So while there may be a small amount of agencies with programs that target infant mortality, it's still possible that there's a cluster of housing authorities in a particular state that target that based on state level priorities. Our survey did not enable us to look at some of those micro trends that might be occurring state by state. So next, we asked housing authorities which populations their health initiatives target. And health-related initiatives are overwhelmingly targeted to seniors. However, housing authorities report targeting health initiatives to a wide array of groups. So 85% of agencies offering services reported that these services targeted seniors. And this is followed by adults, which are targeted by over half of agencies with health initiatives. And furthermore, over a third of housing agencies also target people enrolled in Medicare and Medicaid, those with physical disabilities, psychiatric disabilities, and veterans through their health initiatives. So I'm now going to pass it over to Keely Stater, who is going to discuss the barriers housing authorities face managing their health initiatives, the partnerships they rely on, and the types of activities they're engaged in.
Thank you, Kelly. So to further understand the challenges that housing agencies face in providing services, we asked housing agencies who are providing services and agencies who are not providing services what some of their greatest barriers to offering services might be. And of course, lack of staffing and funding, as you might expect, are the largest barriers for both types of agencies. But if you look in the green, you can see the answers for PHAs without health initiatives, and the gray represents PHAs with health initiatives. So the number one barriers for PHAs without health initiatives was indeed staffing, which you can see in green right here. And this was followed by funding. And then if we look at PHAs with health initiatives, the biggest barrier was funding, and then that was followed closely by both lack of staffing and resident interest. A key takeaway for us in doing this survey, we were a little surprised to see that interest scored so highly. So we thought that this might represent the fact that even though a service is offered to residents, it still takes a good effort in terms of marketing to get the word out to residents, to get them to participate. It may also be important to make sure that the service is easily accessible and to communicate that it's out there for residents. So in addition to putting all the pieces in place to offer the services, thinking about getting residents in the door is also an important piece that we found in our survey. Another key takeaway for us was that you can see over here that lack of partner interest was not as big of an issue as some of the other ones. So it looks like there are a wide range of partners out there for PHAs to engage with to offer these services. Okay. Well, looking at partners, we do indeed see there are a wide range of partners out there. PHAs are working with a very diverse group of health partners. The two biggest ones were community-based providers and public health entities. And the community-based providers, the most common was something like a home health agency. And for public health entities, nutrition organizations are very common, followed by your local health department. Healthcare providers often also worked with more than half of the PHAs who reported services, and the biggest one, of course, was hospitals, but also Medicare and Medicaid agencies. And I see that one of our participants in the webinar falls into that, so we'd love to hear from you later. And then advocacy or funding organizations, research organizations, and then the least mentioned was community resource and development, which would include things like law enforcement or parks and rec. We also asked about PHA partnership complexity. And like most of the answers, this varies greatly among PHAs, with larger PHAs having a bigger capacity to have more complex partnerships. You can see the answers for all PHAs in green. Large PHAs are in teal, and then small and medium PHAs are in gray. So again, larger PHAs reported more formal partnerships more frequently, and that just means they had maybe a formal agreement like an MOU more often, or they had a data sharing agreement, or maybe they shared staff and funding. However, few PHAs had shared staff or funding, and we might think of those as more integrated partnerships. And this is likely because of the challenges we mentioned earlier, that funding is hard to get and staffing is in short supply in the PHA world. So again, we saw fewer mentions of these types of integrations. And it also may be because these partnerships do take time to develop, and we're seeing this as an emergent activity for PHAs. So we may see these rise as more time goes by. Okay, we also asked about the types of activities and the locations that these activities were implemented at. And looking at the types of activities, again, programs took place, they took various forms. Most were on-site or visiting services, about 3/4, but a majority also engaged residents in community health issues like healthy eating or exercise. And then some were specific interventions for seniors or people with disabilities. And then looking at where they were offered, it was really equally distributed between at-home or visiting services, a community hub like a local health center or maybe a community center, and then off-site referrals. And finally, we asked about funding. And we noticed that PHAs are leveraging HUD programs frequently to boost their capacity. But we know that because PHAs mentioned, we can see that funding is an issue because over half of them use their own internal funds to support these initiatives. So we know why that's a barrier. And we can also see that nonprofit partners offered about 50% of funds in 50% of cases. So there are opportunities to share funds with a partner. And of course, large PHAs reported a variety of funding sources and additional complexity there. We also noticed that PHAs were leveraging HUD programs to support these efforts. Most common was the Smoke-Free Initiative. But we also saw HUD programs like MTW Flexibility and the FSS program mentioned frequently. Some PHAs also engage in evaluation of activities to help inform program decisions and make the case for further funding. About half shared data with a partner, and about 1/3 collected resident data. An evidence-based case for support is important to secure outside funding, so we did see some PHAs engaged in this. And now I'm going to turn it back over to Steve to talk about some key takeaways and next steps.
Great, thanks, Keely. So I think there's a number of different domains from this survey. You can dig into greater detail. I think one thing that was striking is that there is so much variability in these on these different topics. Going into creating this survey, prior to doing it with our membership, it wasn't clear to us, what we were going to find. And what we're learning is that there's a wide array of possibilities, which makes it a little harder to say this is the magic wand approach. We're hopeful that this report can be used as a tool in forging partnerships. We included information about PHAs, about the health conditions that people in HUD-assisted housing are facing, so that you can take this report to a prospective partner and say, this is the research that has been done so far. This is what you need to know about at the outset about our space as a way to talk about these possibilities. I know that some of the PHAs I've talked to about the report have said, we didn't even think about doing things in this way until we saw it in the report, to say, yeah, we could work around like a condition, or we do need to focus on a specific target population. Or they said, you know, we really want to work on wellness, but direct that toward a specific resident community. So just, you know, being able to look at what are the ways in which PHAs can be key partners. Like Keely mentioned and the report reflects, you know, funding is going to be a difficulty here. You know, there aren't currently dedicated resources. There is a lot of political capital behind this cross-sector work, and people know that it's, like I said, it's a common sense approach to doing work for people with complex needs, but there are still a lot of limitations. And when we look at the limitations of this work, I mean, the health initiatives that have been reported, they can be vulnerable to further funding cuts. We're already in an environment where operations and capital funds are lower, to say the least, than people would desire. But that's where I think, you know, some of these programs like MTW that provide flexibility for PHAs, they can create a position dedicated to health and housing partnerships. They have more flexibility even if they don't have more funds outright. And we're seeing that, you know, when a PHA is participating in the FSS program, for instance, that they're using, the person dedicated to that program is then taking on additional responsibilities and relationship management role. You know, not to say that they don't have enough going on already in that role, but they're using what they can to make this work. And at CLPHA, we're trying to help as much as we can to foster whatever approach makes the most sense. So what's next? And I think this is as much as a reporting to you all as it is a question and a charge. You know, we are thinking about ways we can expand this research, you know, doing more detailed surveys of, you know, property level surveys, really getting into the weeds of like how this looks within programs, what is the impact of these partnerships, how deep are these partnerships, looking at effectiveness. But, you know, we do want to know, like, we're open to what's next in this work. Like, what do you need to be effective to build these partnerships? What data would be helpful? Is it case studies? Is it additional quantitative detail? Is it cost analysis? We really are open to the input there. We're continually looking at best practices. We often say best and promising practices. A lot of this work across sectors is exploratory, and to some extent, you know, you're taking on, like, it's a risk because you don't always know if it's going to work out, or there's not a blueprint for this work. But at CLPHA, we're looking at what are some bold ideas, what are some innovative solutions, and what are some programs that just work and partnerships that are really trusting. Like, what can we learn from those, and how can we replicate that in as many communities as possible? And we are, in terms of partners at the national level and also at the state level, at the municipality level, we're looking for health partners to work with to further investigate, support, and promote these types of partnerships. I'm really excited to see some of our health partners on the webinar today. Josh Crease from the Arizona Medicaid Department used to work in the housing space. So that sort of moving through sectors is an exciting development. Myself, I'm actually from the health sector. Before I joined CLPHA, I worked in Medicare and Medicaid policy. So I think there's a growing number of professionals working at the intersection of these sectors, and we're eager to learn from other organizations in the health space interested in this work. Just want to share a couple pieces about the work at CLPHA and the initiatives that we're moving forward with. We're continually looking at ways that we can support not just our members, but we do have specific resources for our members, but the field writ large. One of those things we've heard from our members specifically is that they need better data sharing guidance and a template for working with health partners. As Keely mentioned, about 20% of PHAs total are doing some sort of data sharing. Large PHAs report a higher percentage, closer to 40%. but it's still fairly low. And the other thing that we don't know from this data is how deep that data sharing is, how reciprocal it is. We're often at CLPHA talking about, is this unidirectional data sharing or bidirectional? What I mean by that is the housing authority providing data to a health partner or a researcher or other external partner and not getting something back, or are they getting something back? One thing we're trying to encourage is that as much as it can be bidirectional, so that the housing authority is gaining the insights from whatever research is done or whatever data analytics are performed, the better. At CLPHA, we have a health and housing work group. It meets monthly to bi-monthly, depending on the agenda. That's an exclusive member benefit of CLPHA, but it's sort of our brain trust of professionals at different agencies working at the intersection of these sectors, and it's a really exciting, engaged group. We have people from sort of program level work to others who are more in the data analytics space. CLPHA hosts an annual summit called the Housing Is Summit. This year we welcomed almost 300 people to the summit here in Washington. That's double what we had the year before when the agenda was only education and housing focused. So this is an annual conference. I encourage every single one of you to try to join us next year in Washington. Registration is typically free to date. We encourage people as the best of their ability to come and join. Especially if you work at a PHA or you're interested in working with PHAs, the program is really focused on this intersection as it relates to these entities. We also have housingiz.org. It's an online clearinghouse where we're sharing a number of technical assistance briefs, policy briefs, news articles, presentations at this intersection. We have a number of communities people can join and help flesh out the material in those communities, centered around different concepts and priorities in the health space or housing or education world. We're fostering a community there of like-minded and similarly engaged professionals. CLPHA is also continually looking for publications to put out, either smaller publications or larger reports like this. In the fall and winter, we'll be doing more webinars, sort of more translational webinars about the health sector, different entities and concepts, breaking those down for the for the housing sector folks. What are the essential components of this system, and what do you need to know about them? And we're also going to try to better introduce health sector partners to PHAs through those webinars. So I will leave it there, and I also wanted to give PAHRC an opportunity to talk about a couple of resources they've been involved in creating with some of their other partners. And if you download the presentation in the top left corner there, we have links to these resources that they're going to talk about.
Thanks, Steve. So we worked with Leading Age, who's done a lot about creating health sector housing partnerships. They created a Leading Age partnership toolkit, and again, as Steve mentioned, you can get the link to this in the PowerPoint, which goes through kind of the start to finish of how to identify partners, how to present yourself to them, what to do when you engage in a partnership, how to evaluate the partnership ongoing. It's a very helpful resource, and we also did a short video overview of the toolkit with them that you can access via the link here as well, that kind of gives you the short version in a video format of the toolkit.
Hey, thanks, Keely. So we're going to move in. We have about 15 minutes left. We're going to move into sort of a sharing and Q&A session. The chat has been really active, which has been great. We're going to sort of take some of those questions as well. But I wanted to, I'm going to move us into Q&A mode, which, bear with us, this is our first time using this platform. Basically, if you want to ask a question verbally, you click the hand icon next to your name to ask a question, and it'll provide us a queue to ask a question. And I believe we have are you all able to find the icon next to your name to ask a question? Okay, great. We have one of these. Isaac? Isaac, do we have you online?
Can you hear me?
Hi, Isaac.
Hi, this is Lisa.
All right. Lisa, sorry.
Isaac's a very lovely client services coordinator. So I wasn't sure if you wanted us to ask questions or talk about our partnerships. These are all, I like the survey, it's really interesting. I was following the chat, and the idea about doing an analysis of Medicaid waivers by state, I think is fabulous. We have a lot of different kinds of health partnerships. One of the things I find interesting in your study compared to us is we don't pay for any of ours. They mostly pay us. So I was really kind of interested in how that other thing works. They either pay us or write grants on behalf of what they're doing, or we do a shared thing where we're providing the outreach and the free space and they're providing the services. So I was really interested in what you actually get when you're paying for something. So
can you say that last part again?
So I'm really interested in what else you might get when you're paying, as opposed to when you're sort of making these joint partnerships where they're providing service at their expense in our space with our assistance. Because we don't pay for any of our health initiatives. In fact, Sutter Healthcare pays us to house folks under an interim voucher program with wraparound case management for those exiting encampments who are going through a Getting to Zero program that we're running with them.
So if I understand your question, I don't know if it's necessarily that there's payment for services implied here. It could be that the resources needed to foster these partnerships requires internal funding. I mean, to have someone dedicated to working on these things and coordinating different services. But again, it could be a potential limitation of this work is that we ask, how do you fund this writ large without asking specifically what does it pay for?
Well, that's yeah, that would be really interesting. I'd be really interested in that component.
Yeah, and I think that's when we saw the data that said that how do you fund these things, and almost half of respondents said they rely on nonprofit partners. I think the implication there is that the services are being provided by another institution, not necessarily by the housing authority. I do know, I will say, that there are other housing authorities who are paying for certain things or certain access to certain things, and when they find out that service providers in the Medicaid space have to provide certain things, it's an aha moment, and they're trying to figure out how they can make it a smarter investment on their end. But it's a great question.
Thanks.
All right, so I have Katie Escudero from the King County Housing Authority. I know you guys have done a lot of work with the public health folks in King County. Do you guys just want to talk a little bit about sort of your work and where that's led to date?
Sure. So I should also say we've done this collectively with Seattle Housing Authority as well, since we are in the same county. I think the partnership you're referring to is with our public health department, and I was just typing a response back to Alyssa in the chat. I would love to connect with you offline. We did a data match of Medicaid claims data with our 50058 resident data with the health department, and just looked at chronic conditions and service utilization patterns, ED visits, fall child visits, and compared that to the general Medicaid population. And generally, we did see that a couple interesting findings, that our residents at both CLPHA and SHA make up 11% of the Medicaid population. So I think that's a really kind of captivating stat that we've used to garner partnerships with various folks. We're definitely just on this kind of front end stage of that. But anyway, that was an interesting stat we learned. And then just generally, our PHA residents have higher service utilization related to chronic conditions. So we think that this could potentially mean higher instances of these chronic conditions among our residents than the general Medicaid population. So we're hoping to dig into that a little bit deeper. We were selected as one of the sites for the CLPHA, United, and CSH grant that recently came out, and so we're hoping to get more detail and more information from the data match we do with United claims data to see really if the service utilization patterns do indicate higher instances of actual diagnoses. So yeah, that's kind of generally our partnership, but I would love to talk with Minneapolis, because it looks like you're doing work around reducing ED visits, and we're kind of just starting to endeavor on doing initiative planning and kind of strategic planning around the data that we're seeing. So I would love to connect with folks on what you're doing. So thanks. Let me know if there's anything else you want me to cover, Steve.
All right, thanks, Katie. That's great. And I can actually connect you with the Minneapolis folks if you guys want to chat offline. I'm going to introduce Josh Kreitz. He's from the Arizona Medicaid department. And Josh is doing working on a number of things in Arizona that are really attractive, especially knowing that the Medicaid agency is engaged in this work. All right, well, Josh connects. We did have some other questions. Micah, do we have? There was a number of questions coming through the chat. Any of those that we want to address here?
So we were receiving a couple comments about what would be helpful moving forward. It sounds like Cicely and or just Cicely, and then also Josh. We're looking for an analysis of every Medicaid waiver state by state to see what permanent supportive housing language is included, and where housing authorities can learn about costs, both to the PHAs, and then if there are costs or eventual savings for health partners moving forward. Any place to go deep into specific projects sounds like it would be really helpful for people. I don't know if Steve, you wanted to weigh in on any of that.
And Josh, are you on the line now? I think that was partially your question, right? Sorry, Josh, it says that you're connected. I'm not sure if you might be on mute. Okay. So the question was about looking at state waiver, and just for clarity of language. Each state, for the Medicaid program, is required to submit waivers to make modifications to their program, either adding things to it or otherwise modifying the system. This is the mechanism through which states have typically looked at innovation projects and doing things sort of outside the box. So it sounds like there's an interest in looking at sort of state by state what these waivers look like in terms of supportive housing language. I can use this as I can follow up on this with those who ask the question, but I'm thinking that this analysis might already exist or some form of it. I know that at the Corporation for Supportive Housing, CSH, they're one of our close health partners. I know that they've done some analysis of the state waivers to date, and so I'd be happy to share that with that. I'll connect with my colleagues there to follow up with that resource. Okay, so I'm going to try to, Michael O'Neill should be connecting. So thank you guys for being patient. This is a new platform for us.
In the meantime, we got a question from Latasha. Sorry, I don't know where you're coming from, Latasha, but you're asking about how PHAs are using the FSS program for health partnerships. Do you want to weigh in on that, please?
Yeah. So what we saw in the survey, at least, is that FSS was being used for health partnerships. We can't, from the data, surmise exactly what for or how that's being used. I know that anecdotally, I've heard that those who are responsible for FSS are then tasked with, extending their work to health partnerships. So it could be a shared staffing or additional staffing responsibility because they have dedicated resources for that position. They're adding to that portfolio. Kelly or Keely, do you guys want to add anything to that or any other questions?
No, I think we're having a really great discussion on the chat. A lot of people are providing some input about what they do and also asking questions with each other. So I've been glued to the chat.
Anything that you find interesting from the chat you want to elevate here? Keely, is there anything from the chat that you wanted to sort of share with the group? All right, I think we're having technical difficulty. Michael, are you connected?
Hi, Steve. This is Keely. Sorry, we were muted. I was just mentioning, per the chat, Carol was talking about their approach to partnerships. And I found it really interesting that she was saying how they really like to go, she quoted, deep into the partnership to kind of look at what worked and kind of the mechanisms that were particularly successful, and also kind of focusing on the things that didn't work to kind of figure out how to iron things out next time. So I wondered if anyone wanted to comment on kind of their approach to partnerships, those agencies that are working with others, and what you do to kind of ensure success and get ready to implement something.
Great. We also did have a question. The question Michael wanted to ask, he chatted it to us, was about getting the data sharing resources that we mentioned. So CLPHA is in, we're currently working on a working draft to share, basically for people to use it and provide feedback and further refine this tool. This will be released in September. We're hoping to get it out for review and for people to test drive it and use it in different health partnerships. Included in that template, we're going to have some high-level guidance. For instance, like what questions do you internally need to ask yourselves? What do you need to know about your data capacity? What do you need to know about, which staff within your agency need to be a part of those data conversations? What data are you hoping to get back? What does that mean in terms of privacy and privacy compliance? And are you thinking about using a data intermediary in order to get personally identified data and using that in your work, or at least getting the insights from that data to influence your work? we have any other questions from the line? I will make a plug. You know, I'm really encouraged to see the chat so alive. I would love to encourage all of you to join housingism.org. We have forums on there where people can connect. I'm also happy to connect you all by email after this webinar as well, in case people want to connect with each other. I'd be curious to hear, you know, what do you want to learn from your peers? That's something that we're trying to facilitate in our work, both at the summit but throughout the year. And we're looking for additional ideas for webinars and, like I said, additional research that we can do to be helpful in this work. Keely and Kelly, is there anything you wanted to add as we wrap up?
No, just thank you everyone for joining today. It's been really interesting.
Okay, great. So we'll do a follow-up email after this webinar with these files and some follow-up items. Feel free to connect with us individually as well as we move forward. Thanks, everybody.